So we discussed how to incorporate the genome sequencing in clinical practice. And now the platforms are becoming more sort of like user-friendly. There's plenty of clinical assays that have been used in different centers and institutions, also by commercial vendors that are accessible even to the community oncologists anywhere in the world. The question is, how do you use these things to advance treatment options and diagnostic options for patients with lymphoid malignancies? So I showed examples about how we use these things. How do we refine the certain diagnosis? Frequently, when we meet in tumor boards, even in a place like Memorial Sloan Kettering, there are cases that are unusual, atypical. You can't put them in a well-defined bin, like this is diffuse large B-cell lymphoma, or this is a Hodgkin lymphoma. They look funny under a microscope. They have an unusual immunophenotype picture. And now we're using more and more these genome sequencing data to refine the diagnosis. Then we can put it in a well-defined bin that can guide therapy. And that's an example. This is an evolving field, of course. The other one is like how to select patients based on these fingerprints of the tumors with genomic data. A beautiful example was mentioned yesterday by Frank Morshauser at the meeting, where he pre-selected patients based on EZH2 mutations. If you take patients with follicular lymphomas in an unselected way and treat them with the EZH2 inhibitor, the response rate was about 39%. But if you zoom only on patients with the EZH2 mutant, the response rate goes way to 92%, which is remarkable. So although the fraction of patients with EZH2 mutations is only 15%, so the impact is not probably huge, but it's a beautiful example of how pre-selection based on genetic biomarker can improve response rate. That's what everybody now looking for. So we're interested in expanding this by looking at multiple genetic alterations in what we call a master protocol, where you can sequence all patients, and then depending on their genetic fingerprints of the tumors, you can assign them to bucket A, bucket B, bucket C, and each one would get different treatment based on these fingerprints. And that's, I think, where the field is moving these days.